Besides, if you're in there starting 3 IVs, is that patient going to have a whole lot of confidence in you at all? No. Okay, moving along. Clean the site. So, like I said, we have alcohol preps and there are chloride preps. 2 different. There's other ways, but let's just go with those 2 for now. Not open up this book even bigger. So, alcohol pads. The alcohol pads you're going to run in circles from the inside out, and you want to do it while counting 1 all the way up to 30. Ready? So we got 1, 2, 3, 4, 5, 6, 7, 10, 20, 30. You understand. But as you're going out, you're doing that. The process is pushing away all the bacteria, all the bad stuff, cleaning it as you're disinfecting it, right? Chloride preps. Chloride preps are a completely different thing. That's the thing that you crack, and then you back and forth in the area. And it's less about killing the object with the alcohol. It's more about the friction that actually breaks up bacteria and pushes that out of the way, right? So that's why it's back and forth on those instead, because it's more about the friction. Next, administering the IV. Boom, we're here. We get to do this now. We understand it. All right, so before we administer the IV, we got to understand how we do it. So, angle of 15 degrees. Coming over here. Get your 15 degrees on this side right here, right? If you're coming down, if you're coming at that vein, and you're coming down at a 15-degree angle, you can hit it, you can go into it, you can do your thing, you can push your catheter into the vein, and you're good. Now, on the other hand, if you come at it like this, it's going to take a long time to go through all that. You're just causing them pain. Any more than that, I mean, you can obviously change it up a little bit, 10 to 20, but if you're coming at it like this, and you're doing them any favors, so then you go through the other side, it's going to be very easy to go right through that vein. So we don't want to do that. No infiltrations. It's just this little bit of a vein here before you break through the other side. So since I've got this over here, and I totally forgot earlier, this is what it looks like, the side of it. Obviously, this is exaggerated quite a bit, but we have your IV here, your skin here, red blood cells, and your vein. Again, it's exaggerated. I get it. But IV size makes a big difference, a big factor in what we're doing here. If we go with something like a 14 gauge like this, we're good. Pretty much anything we need to is going to go through that vein or through that IV. If we're running 24s, something like that, you're not going to get a lot of fluid through here. Also, if you're running packed blood cells or something like that, are you going to be able to get those red blood cells through that teeny tiny 24 gauge? You can, but chances are it's going to lyse a lot of your blood cells, your red blood cells. So you want to get as big as you can to a degree. You don't want to automatically go to 24s for every single patient because it's just not going to work for you. Okay. Next, bevel up. We went through that. This is what your bevel lip looks like right here. It's that scoop, that hook, right? It's almost like a scoop, but that's your cutting edge right down here. Also, this is the look, what it looks like from the top. It's just that hole. That's the bevel. Bevel is always up. Again, you can start the other way, but you'll know it because they'll make some noise because you messed up and you're hurting your patient, and that's not who you are, and that's not why you're doing this. Okay, so hold traction. So here's your veins, here's your arms. These little things, they move. You ever heard of somebody say, I got rolling veins, I'm sorry? Right? They move. So what you're going to want to do is you're holding their arm in place so they don't immediately you stick it and they go, they pull away, right? So you're going to hold onto that arm, and with your thumb, you're going to hold traction. Now, it doesn't move as much. You've got it down. Just hold it, pull. Hold it, pull. On the skin, right around where the IV goes. And then, of course, when you keep your hand out of the way, and then you're going to start your IV right here. Something I forgot about, I have to mention. It's a thing that bugs me. I'll be right back. Okay, so you've got your gloves, right? You got your BSI, you're working. Not you, because you know better. Not me, because I don't like it. But a lot of old-timers, old schoolers that I've seen will take their gloves because they're not used to them, because way back when we didn't use these. We just dove right in without any gloves. But a lot of people will take their glove and they will twist it. Oh, these are good gloves. It's really good gloves. And they'll take the little tip off so that they can now feel that vein a little bit better. If you can't feel that vein through something like this, you got problems. So don't do this. What's the point of this? What's the point of wearing your gloves at all now? You just broke that field. So don't do it. It makes me nuts. Don't do it. I cringe every time I see it. I don't like it. Please don't be one of those people that do that. Okay. Sorry, side tangent there. Okay, so we're at hold traction. Use that thumb. Then you're going to advance the needle. Boom, start an IV, we're there. Okay, so you're going to advance that needle, push it in. Now you're going to watch for a flash. So this is what your IV looks like already, right? When you get it in here, through the skin, into the blood, that blood can now run up that needle, right? Because it's got that hole. And when it does, it's got this little chamber right here. Okay? And this chamber, as the blood comes up, this chamber will fill with blood. Just like that. And now you know you're in the vein. That's called flash. So you watch for a flash. When you get the flash, you're there. Stop. Because your needle is in that vein, right? Boom. Now, advance the catheter. We went over this before. You saw it. You got that little lip there. You're going to advance the catheter, depending on obviously the needle you're using. Some of them have the tip or the little advanced piece right here on the hub. But anyway, you're going to advance the catheter to the point where it locks. That's that lock thing. Now, I can't stab myself anymore. Kind of silly to try, but now you got it like that, right? Okay, so it looks just like that, right? From coming at you, it's got the straw on the outside, needle on the inside. Advance the catheter, withdraw the needle. Release the tourniquet. So if you don't release the tourniquet, and I've seen this before, you've made your tourniquet, you've cleaned your site, you've started your IV. Now you're getting ready to take the needle out. This causes all the pressure down here or up here, wherever it is. So now, when you pull that needle out, blood's just gonna be coming out. You've got it under pressure, just like arteries. So you're gonna wanna, I did this wrong. So here's your stuff. You're holding traction right down here. You come up here, that free hand is gonna just pop it loose. Okay. Then you're gonna release traction. So you popped your tourniquet, you're still holding traction on that thing right there. You're gonna go ahead and, you got there, you're gonna release traction, you're gonna come up here, You've released your tourniquet, you're gonna come over here, you're gonna hold onto your IV, and with this hand, you're also gonna stabilize that arm. Then you're gonna come above with this hand, and you're going to push down on not only the vein, but the catheter itself. The catheter is now inside that vein, and you're gonna push right there. The reason for that is you're going to stop blood flow from coming out that little hub while you're pulling the needle off. So hold pressure. Release traction and hold pressure. Release traction and hold pressure. Story time. So I was, 20 years ago, I started my IV class with my wife. We went through class together. Had a great time. Back then we started IVs on each other. Glad we got away from that, but we used to start IVs on each other. We were learning. Prior to class, she fell off the bed. Long story. She fell off the bed, broke her arm, full arm cast, this one here. And with IVs, obviously, you already know now, you need two arms to start an IV. Because you've got to do one here, and do one of these, right? So she pulled off the tourniquet, and she doesn't have that arm to hold pressure to stop the bleeding. So she pulls off the tourniquet, and she's grabbing her lock and her flush to hook that up, and I'm just bleeding all over the classroom floor. And let me get that from you, babe. Sorry. Anyway, so I got down here. Let me come back up here because I forgot something. So release the tourniquet. I cannot stress this enough because I don't want to see you guys hurt patients. Release the tourniquet. Release the tourniquet. Release the tourniquet. Yes, you can hold enough pressure that you can stop the bleeding from coming through when you pull that needle off. But let's say your patient's altered. Let's say they have dementia or Alzheimer's, or they're unconscious for some reason, and you're not paying close enough attention, or somebody else isn't. You just left a tourniquet on that arm. How long is it going to be before you come back and check on that arm or notice it? If the patient can't tell you it hurts, you just lost the arm. I mean, you've done some serious damage, right? Let's not do that. We're here to help the patients out. Okay, remove the needle, not the catheter. We went over that up here. Sharps container. You're gonna have a sharps container close to the bed. Get it in there as soon as you can. The last thing you want is to get a stick from a used or dirty needle. You love these patients, but you don't know these patients. You don't know where they've been. You don't want to share blood with them, okay? Just right out the window, let's just not. I've seen it before. People forget about their needles. Set it on the bed. It happens. It's not a big deal. You forget, but you set it on the bed. Next thing you know, CNA comes in, other nurse comes in, they go to move the bedding, boom. Now they just got one. Who do you think they're going to blame? Now they come down with any number of things. You're at fault. What are you going to do for these people? What are you going to tell them? I'm sorry, I forgot. Put it in the sharps container as soon as you can. If you have a sharps container within reach, drop it right then. Just do it. Next, connect the lock and draw back. This is a thing just like starting low and working your way up. This is an old school thing that a lot of people have gotten away from and a lot of people don't do. It's an extra step and people get lazy sometimes. Let's say you go all the way through. You got your flash. You know you're in. But you push through and now, let's say the patient's got soft skin. Let's say they're on warfarin or something like that. Their skin is all loose. And you just push your catheter right in through here, underneath that skin. You're not in the vein anymore. What's going to happen when you start giving medication into that? It's not in the vein. You're putting D5 in there or something like that. You can do a lot of damage. So you're drawing back. You've got your hub hooked up. You've got everything hooked up. If this is where it's supposed to be, and you, what they call a drawback, and it's just pulling back on the syringe. This one won't work because it's already at the extent. So if it's in where it needs to be, if this is in the vein and you draw back here, like so, you're going to get blood returning halfway up here. Okay? And then just push it back in. That's it. That way you know where you're supposed to be. You know that this straw is in that vein. There's no question about it. Next, flush with 3 mils of saline, not heparin. People used to say flush Heplock, flush with heparin to keep it free. We don't do that anymore. There's a lot of problems. A lot of people got hurt. We don't do that anymore. That's an old thing as well. 3 mils, that's my go-to. Depends on your hospital. Check with your hospital policies. Most people is 3 mil. Because you don't want to be, every time you're coming in, every new change of shift, you're flushing 10 mils. We got fluid issues, right? You don't want to overfill these patients. Just go with 3 mils or check your hospital. Assess for infiltration. So when you flush, if you're up here, if you're between the skin and the vein, or even sometimes below the vein, you're going to see. You're going to flush. It's not going to flush quite so well. When you flush, it's going to bubble. That's your infiltration. You know you're not where you're supposed to be whenever that happens. On the other hand, what's really cool, and I actually get a kick out of seeing it every time I do it. You got your flush. It's hooked up to your lock and your line to your hub in the vein, in the arm in the vein. You can actually see the veins on, let's say you've got a pale patient or a light-skinned patient, where you can actually see the blue, right? You can actually see some of the blue. Maybe I'm not light-skinned enough, but you can actually see some of the blue. Ooh, I need to clean that. I've been working in the garage too much. So you can actually see some of the blue, right? When you flush that, a lot of times, you'll see the vein, the blue in the vein, disappear. And the vein will just go away. And it's not just right there at the site. It's like all the way down. And it's so cool to me. I still geek out every time I see it. I don't know why. I just like it. Okay. Another good way to know you're in where you need to be. Okay, so apply Tegaderm patch. So for this one, this is another thing where you can mess up on. You got your hub. You got your extension on there. Now it's time to apply your Tegaderm, right? You could throw that sucker right on there, That side is covered, you're good to go, right? Now, what if you have to change this out? That's a little difficult. Now you got to peel all this stuff up. So, on the other hand, if you put it like so, you're only covering up the hub. Now you need to change out this thing because it's old or there's a problem with it, complication. Boom, you can still do that. And your sight is still clean and covered. So that's what I prefer. Okay. You can also apply, obviously you have to obviously use tape or paper tape as well if you need to. But I like tegaderms. Label a site, initials, date, time, and gauge. Like I said before, with the tegaderm patches, it comes right there. And you can have tegaderm patches, huge tegaderm patches. You can damn near write a story on that thing, right? So remember, with documentation, if you didn't write it, it never happened. These things will sit there for a while. The nurses that are taking your place don't know when you started. They haven't seen it in the chart. Maybe you forgot. That's going to sit there for a long time, and it's an easy access for damage, for infection, and everything else. Let's label it. Make sure we know when it was done. Down to documentation. You're done. If you didn't document it, it never happened. So document it. Ta-da! You've started an IV. I think I covered everything here. Let me go ahead and show you on my arm what it looks like, and then we'll get into some other stuff later.